All right. Hello, everyone. Thank you so much for joining us today. If you are joining us again after last week, welcome back. If you are new, welcome. Today we have Leslie Mader and Anthony Nappi from InnovAge with us to talk about Bedroom Falls and the InnovAge program. So welcome and thank you.
Okay. Well, thanks for having us again. I'll just introduce myself quickly and then have Anthony introduce himself. My name is Leslie Mader, and I work with InnovAge as their strategic account executive for Virginia and Colorado. And we'll be telling you a little bit more about our program briefly, and I'll let Anthony introduce himself.
Sure. Good to see everyone's name, at least again, or most people's. I'm Anthony Nappi. I'm a physical therapist and registered nurse with InnovAge PACE. And I've been with a PACE program in general for about 10 years. And I'm happy to be here today again, this time to talk about Bedroom Falls.
Great. I also want to encourage everyone, as Nina mentioned, you know, as we're I'm going to describe the PACE model, and then Anthony's going to go into Bedroom Falls. Be thinking about people that you work with. Think about what you're seeing in your buildings. We'd love to have conversations with you during this presentation about, you know, what are you seeing when you walk into someone's apartment? What kinds of resources do they need? And so we can brainstorm with you about possible resources if our program in particular is not located in your town. So with that, I need to find where is it? Sorry. Hold on. There we go. Okay, let me just get this situated. Oh, come on. There we go. Okay. So this is our handy dandy slide. See, I'm just gonna get rid of that. Okay. So today what we're going to be reviewing is the PACE model of care. We're going to go through, Anthony will go through falls, give you a definite definition, falls in the elderly, fall risk factors, bedroom falls, and then we're going to discuss different resources, and hopefully you can give us some examples of what you're seeing in your buildings and what you're coming across with the folks that you work with. So this group is different, I believe. You're all from either Pennsylvania or Virginia, and some of you were on the call last week and some were not, or our last call. So I'm just going to go over a very high level view of what a PACE program looks like. There are, as you'll see here, there are many PACE programs in the country. It's a national model of care that's been authorized and licensed by the Centers for Medicare and Medicaid, and that is for older adults that are 55 and older. There are over 272 PACE programs in the country, 31 states, serving actually over 60,000 older adults right now. And really for you to understand is this is a holistic model of care where we help older adults who are dealing with aging issues and a lot of illnesses. In the model, PACE becomes the insurance and the medical provider. And so we're a type of an HMO, but I like to say we're kind of on steroids because it's not just healthcare, but we do so much more, and we'll be telling you about that. And also PACE is a long-term care option with Medicaid. So it's part of, it's a Medicaid waiver, in the waiver program. Okay, there we go. So any PACE program in the country, these are the 4 bullet points of eligibility. You have to be at least 55. You have to live in the certified zip codes of the PACE program. And I got an email from one of you last week. I was speaking with you and you were in more of a rural area. I know in Pennsylvania, we're primarily in Philadelphia. In Virginia, we're in Roanoke area, Charlottesville, Richmond, and Hampton. So those are kind of the areas that we have the zip codes in, and we can speak with you offline about that. The third bullet point for any PACE program is that the person needs to be able to remain safe in the community at the time of enrollment. So they have to have an address. They cannot be homeless. And then lastly, each person when they're being enrolled is assessed functionally, and they have to meet the state's skilled nursing home level of care. Now that phrase is a misnomer because I think it makes people think that they're bedridden. These are adults who are struggling with activities of daily living, and things like mobility, having a hard time dressing, bathing, feeding themselves. And there's a full assessment process that happens by an outside agency to assess for that level of care. But if the person meets all 4 of these, they can enroll in any PACE program. This circle of care really shows well what a PACE program does for someone. So when someone enrolls with a PACE program like ours, we become their primary care provider. We have contracts with specialists in the community, which we coordinate all of that care. We make the appointments, and then we actually provide transportation to our center and to the specialists that they're going to go see. Also under the roof of every PACE center is not only the clinic, a medical clinic, is a rehab gym where they can have endless PT and OT and speech therapy. That's part of their plan. We have a dental clinic where they can get dental care, everything traditional dental work done except for cosmetic surgery, and also implants are not covered. Then we have day rooms, and that's really where the social model kicks in. Day rooms where people can hang out, they can come in the morning, get a hot breakfast, interact with folks that they're getting to know or not, engage in recreational activities, get lunch, or maybe go to an appointment, come back. So it's a place for them to be for the day, and it's really a great respite model for caregivers. So someone can come to a day program 5 days a week and give their caregiver or their loved one a break for the day. Also, what we provide is their DME, their durable medical equipment. We do at home, we do home care. We don't do sitter service, as we discussed, I believe, last week, but we do task-based home care. So we go through and assess what someone might need, if they need the house cleaned, if they need help with the dishes, preparing meals, with bathing. We come in, we do it, and then we leave. And we really use our day program as a place to help someone be during the day to have the care that they might need and attention that they might need. We deliver all prescriptions in prepackaged kit or a box, and it comes to their home, and it's marked exactly when to take things, and so they don't have to have pill boxes anymore. And then, as I mentioned, we do recreational activities in the day center. So you can kind of see there's this whole kind of holistic model of care that I call wraparound services for the older adults that engage with us. We also spoke last week a bit about our interdisciplinary team, and I know that Anthony will be speaking a little bit about how he integrates, assessing for falls and how the team works on that as well. But just as a reminder, we have 11 folks on this team that know each person intimately. They work with them, they put together a care plan, and they can, and what I like about this model is the doctor's not the one in charge. It's very democratic. Every single person has an equal voice, and they can speak up, they can disagree with maybe a plan of care or recommendation. And so there's a lot of collaborative communication that goes on with this team. Okay, Anthony.
Excellent. So let's get to the next slide. We'll talk a little bit generally about falls, and then more specifically with respect to bedroom falls. But just to set the stage, one might think, what you have to define a fall, but really for the purpose of data collection, quite frankly, we did need to choose a definition of falls. When I started at the original PACE organization where I worked, there were actually, we were started from the ground up, so we didn't have any participants. So we chose to go with the World Health Organization's definition of a fall, which is basically an unintentional or inadvertent lowering to either the floor or another surface lower than where you started. So that may be someone's trying to get up from a sofa, falls back onto the sofa, that counts as a fall. So any inadvertent lowering to another surface is defined as a fall per the World Health Organization. And then briefly, with respect to the statistics, they really are staggering. 34,000 elders die of a fall every year. This is 2019 data. Just to put that in perspective, about 40,000 people in the United States die every year of a motor vehicle crash. 3 million visits to the emergency department, and then $50 billion in healthcare costs with a B. And that kind of reflects on the serious nature of falls, that $50 billion. That's not just falling, going to the emergency department, getting checked out and then going home. That includes the type of falls that we as a PACE organization and healthcare providers are most concerned about, which are injurious falls. Those are falls with hip fractures or head injuries and the cost of rehabilitation and hospitalization and that kind of those kind of expenses after someone has a fall. And something I find applicable to just falls in general, and I found throughout the course of my career, and you as housing coordinators may find out and may be observing already, is oftentimes falls are underreported by elders. Oftentimes elders, they view falling and their own falls as a threat to their independence. And so oftentimes they won't report that they fell to their healthcare providers or the healthcare team or doctors. They'll kind of, I didn't really fall. And over the years, I've also observed a very common kind of an explanation for a fall where people try to discount their fall in a way that I'll ask if they've fallen recently. No, I don't fall. I've never had a fall. And based on my observation, I'm thinking this person has to fall, right? Just the way they're getting around and just what I'm looking at thus far during the assessment. And then as I get to know the person, I'll kind of probe gently in different ways to explore their fall history. And oftentimes people will mention, oh, well, I kind of went down to my knee last week, but that was my fault. And that quote, but that was my fault, is unbelievably common, as if it doesn't count as a fall if it was your fault. But anyway, my main point there is they do go underreported. Folks do view falling as a threat. Well, if I fall, that means I won't be able to drive, or that means someone's going to put me in a facility and that kind of thing. We want, as a PACE organization, and my team, we want people to be open about their falls. And we try to encourage their reporting of falls to the team, because that helps us identify patterns and help to address kind of the larger problem of falls. How can we solve this, or how can we make an impact on specific elders with respect to their falling? We can go to the next slide. So fall risk factors. This is a long list, and this list could go on for 3 or 4 more slides with respect to fall risk factors. These are just some of the big ones and the ones that stick out. The 3 at the bottom in bold are what I would consider non-modifiable fall risk factors, right? So the history of falls actually is a big fall risk factor. That is a predictive factor for future falls. Age and cognitive impairment. As a team or as a physical therapist, we're not going to be able to fix the non-modifiable, obviously. But we try to focus on the modifiable fall risk factors. So as you see, impaired vision and mobility, incontinence where people hurry to the bathroom, resulting in a fall, environment and modifications that need to take place, foot and footwear problems, number of medications, that kind of thing. So that's our focus, is the modifiable fall risk factors. And I try to envision someone's fall risk as kind of, a big circle. And how can, as a team, and in my case, in a PACE organization, that interdisciplinary team that Leslie showed you that slide of, how can each of us kind of take a bite out of someone's global or more complete fall risk in general? I mean, a physical therapist, on the front end, when someone enrolls in our program, I'll do an assessment, look at their shoes and their balance, their equipment, their assistive devices that they use to get around, and I'll optimize things from my standpoint, again, to try to take a bite out of that bigger fall risk. The occupational therapist on the front end of someone's enrollment in a PACE organization will go and do a home safety assessment, look for clutter on the floor, extension cords, tub and bathroom, see if grab bars can be installed. I'll do a home visit as well, see if a ramp might benefit the person getting in and out of the house to provide a bit more safe home ingress, egress. The nurse will also do a home visit on the front end and go in and look at the patient's or the participant's medications, see what things look like. Are they taking old expired medications? Are they taking too many? Are they not taking their medications correctly? and then bring all that information back to the team, and everyone will take their part. And again, just try to take a bite out of the risk for future falls. And we know going in that we're not going to eliminate falls. That's not a realistic expectation with frail elders. What we try to do is mitigate someone's risk of falls. We can go to the next slide, and I'm going to take about a 2-second break. Can you all hear the lawnmower?
No.
Okay, all right, that's good. There's a lawnmower outside suddenly, and I just wanted to make sure that wasn't getting in anyone's way. We can go, I think, back.
I went too far, sorry.
Yeah. So more specifically, with respect to bedroom falls, again, kind of during that assessment on the front end of when someone enrolls in a PACE organization, and then periodically thereafter, maybe someone will move in with a different family member. Maybe for some reason their housing changes. We'll go as needed and periodically to make sure their home situation is safe. And over the years, looking at falls data, at least in the PACE population, the bedroom is the most common place where folks fall in our experience thus far. So we talk about a safe bed, safe closet, safe lighting, and safe shoes. With respect to the bed, I always look at bed height. I look at chair height and bed height. And it should be, it should be basically someone can sit on the bed comfortably, knees at about 90 degrees and feet flat on the floor. You don't want a bed too low. That results in struggling when someone's trying to get up, and oftentimes during or after a struggle like that to assume a standing position, people become unsteady. The opposite with a bed that's too high. Oftentimes people, when they're getting out of bed, if it's too high and they're trying to tippy-toe down to the floor, they'll slide off. Or getting into the bed, they'll slide off the bed. So bed height. We try to make sure they're not using too many quilts and blankets and that kind of stuff that would get caught up in their feet when they get up from the bed. I always encourage people, if they're using an assistive device like a cane or a walker, that kind of thing, that's right next to the bed. And that whenever they get up during the night, typically to walk to the bathroom, that's right there for them to use, rather than do the thing where you're reaching for the bedside table and then reaching for the door, trying to balance that way. And then finally, often one of the most common pieces of equipment that we provide for folks in their homes are, I usually call them a bed rail or a bedside rail. You also see the term bed cane, but it's basically a grab bar that's hooked up to a board, and the board slides between the mattress and the box spring and provides them kind of like when you see a hospital bed with a side rail. It's shorter than that, but something right next to where they would be sitting when they're sitting on the edge of the bed. Give them a little balance and something to push up on when they stand. We find it very helpful. And then just generalized clutter in the room. You just want the place to be fairly neat and that kind of thing. And those are all kind of aspects of someone's room that we would address as an organization when we go in and the various disciplines assess and try to clear things up and again, reduce fall risk. With respect to one's closet, step stools are out of the question, obviously. You want, if the person has maybe clothing and that kind of stuff on a shelf, you want it optimal height where they reach in, they're not bending over too much, they're not reaching too high. With respect to their closet, keep that a safe place. As far as lighting, bedside lamp is great. And then night lights, typically we recommend night lights kind of along the path to the most common destination at night. Again, typically the bathroom. And then finally, shoes. So we talk about oftentimes, so a decent slipper, not flip-flops or slides, something that goes around your heel, but a decent slipper. I wouldn't expect someone to fully put on shoes when they're getting up in the middle of the night, but a decent slipper that is supportive and hooks around their heel. With respect to shoes, a slip-on shoe is fine as long as it goes around the heel and has what's called a crepe sole or a flat sole. Again, so there's not a heel, there's not an uneven surface where someone's trying to walk. Let's see what the next slide is here.
I think we're on to discussion.
Any questions or anything thus far? As far as resources, I would say the single best resource from the standpoint of falls is the CDC site that I listed there. The STEADY stands for Stopping Elderly Accidents, Deaths, and Injuries. It is top notch, not only for falls, but for other types of medication errors and that kind of stuff. It is fully encompassing with respect to elder issues with accidents, deaths, and injuries. And it's an excellent resource. I use it on a regular basis. It's all evidence-based information and really a go-to. And then, more locally, any elder organization in your area, falls are such a big topic, they're going to have fall resources. Can I repeat the CDC website? Is that what you mean? The STEADY Stopping?
You've seen chat? I'm not seeing anything in the chat, are you?
Yes. It's the cdc.gov/STEADY, STEADI, which is Stopping Elderly Accidents, Deaths, and Injuries. So briefly, good. Okay. So this is an example of someone we assessed a while. This was years ago in the PACE program. And it just kind of, in my mind, kind of illustrates an interdisciplinary approach to fall risk mitigation or reducing someone's fall risk. We enrolled a woman who was a frail elder, lived alone in the community, and happened to be falling on a nearly daily basis, an unbelievable amount of falls, certainly from the standpoint of data, an outlier for us. And so as a team, we went and we really did try to focus on what the situation was. And this was an example of someone who didn't really want to tell us a lot about falls because she wanted to stay in her home. But as we built trust, I talked to her about, look, please tell me every time you fall, I want to know, because we want to know a pattern. And so it turned out that many of her falls were doing what I consider what I call functionally complicated tasks. So this was a frail elder. She was still hanging her laundry on one of those drying racks. She was doing her laundry. She was doing her dishes, putting dishes away. And those were the kind of activities that resulted in her falls. And so we had already done the obvious things, the things where I supply some equipment, the occupational therapist does a home safety assessment, make sure the pathways are clear. But what she really needed was to stop doing those risky activities. So we bulked up her home care from a PACE organization standpoint, and we started doing her laundry. We did her dishes, we did her meal preparation, and her falls drastically reduced. We didn't, again, we're not going to eliminate anyone's falls, but that was kind of an example of, well, we did our normal routine and that didn't really do it. But when we really dug a little deeper and encouraged her to report her falls, we found, okay, if we can take some of these more difficult things off her hands, she's not going to take those risks through the completion of those, the attempts at completion of those functionally complicated tasks. So please, if you're having any questions about a resident you may know or that kind of thing, I'm happy to hear you out. And I can't make recommendations with respect to a clinical recommendation, but yeah, I'm happy to shed any light on something if you have any issues outstanding.
I'm wondering too, if you folks do if you do presentations to your residents about falls. Hey, Sonia, unmute yourself. You can talk. Can't hear you. Oh, somehow you're muted.
Can you hear me now?
Yeah.
Okay. Good afternoon, everyone. Yes, we have presentations yearly, and they're normally put on by PCA in combination with Center in the Park here in Philadelphia.
Oh, great. Mm-hmm. Great. And do your folks attend it?
Yeah. We even had the Philadelphia Fire Department come out one time, and as they were doing fire safety, at the end, they did a thing on fall prevention.
Great. Great.
Oh, I'm going to mute myself again.
So I'm just curious, I mean, Anthony mentioned it too, if there are people that you can even envision right now, you know, I'm not sure if you go into folks' apartments often, but
Not often, but from time to time. And then I have a pretty good rapport with most of my residents, and they're usually pretty open about when they've fallen, or if they feel like they're getting to the point where they need additional assistance. And that's where I come in.
That's great.
Sonia, the fire and rescue is a good point that I forgot to bring up. So they're key partners with respect to our organization in Virginia, where I am with respect to PACE. As far as one of the things that we do on the front end of enrollment, especially when someone lives alone, but sometimes even when there's a caregiver and they spend some time alone, is we issue one of those personal emergency response systems that it's the button that when you fall, you can press a button, it'll call EMS. And EMS partners with us for lift assist quite often, kind of in the middle of the night, someone falls. They may not be injured, but they may need just to be checked out at home and assisted back up. And so they help us greatly with respect to that.
Absolutely. We kind of deal with that too from time to time. Not so much right now. We're going through, I guess, a period of getting lots of new people in, new residents in, and they seem to be on the younger side of the elderly population, anywhere between, I guess, 62 and 65. And this is a pretty active community.
Mm-hmm.
That's great. Anybody else have any situations or residents that you're thinking of? Okay, let's see, we have, oh, this is up there. Okay, well, I don't know if there's anything else, Anthony, if you want to share anything else, or if you feel like you've covered it.
I think that's all I have.
Yeah.
Well,
All
thank
right.
you for making this available to us. I greatly appreciate it.
Sure.
Thank you all for your time.
Yes, thank you, Leslie and Anthony. We appreciate your time.
All right. Take care.
Thank you. Have a good day.
Thanks. Bye-bye.
Bye-bye.